Hey everybody, this is Leslie, and you're listening to Duologue with Leslie Heaney. This past Saturday, October 18th, was World Menopause Awareness Day, you may not have known, and here to bring us all the latest and greatest in all things menopause is menopause specialist Dr. Kat Brown of Winona Health. Winona Health is a telehealth company that empowers, educates, and treats women throughout the entirety of their menopause journey. In this episode, Dr. Brown and I talk about all things menopause, symptoms, the latest treatments, the latest research around hormone replacement therapy, and what the FDA is also doing around menopause and in this space. Dr. Brown gives us all the latest, hot off the press, research information. This is an episode you will not want to miss. Dr. Brown, I'm so excited to be here with you today, just a few days after World Menopause Awareness Day, October 18th. Thank you so much for being here.
Well, thank you so much for having me. It's a pleasure.
So I did an episode about 18 months ago on the subject of menopause. And in the course of that time, I feel like it has just become, and maybe it's because of my algorithm on my Instagram or my age, and I'm looking for it, but I feel like awareness has grown so much around this issue, right? We all, as women, will eventually go through this process. And, there have been people like Dr. Mary Claire Haver, who's out talking about it. Naomi Watts, the actress, has a whole product line to kind of deal with some of the symptoms around it. And I don't know, there's this amazing woman, if you're on Instagram, Dr. Brown, called Melanie, and she has this I Do Not Care Club.
Oh, yeah. She's been in my feed all over the place. It's wonderful.
Oh, she is so great. I was wearing like pajama bottoms to go get the mail or something. And my kids were like, "Are you wearing pajama bottoms?" I'm like, "Oh, yeah, I'm a member of the Do Not Care Club." My husband's like, "Can we care a little? Can we just care a little?" Anyway, I feel like when you hit a certain age, it just sort of does capture that, the feeling among us ladies that are going through that process, right?
It sure does. And I tell you, like, it's liberating to not care.
Yeah.
I have to confess, I wore pajama bottoms to drive my son to school this morning.
Yeah, I'm good.
I was like, you know what? I'm not getting out of the car. It's totally fine.
Yeah. It's so great as when you hit that part of your life where you're like, you know what? I don't necessarily have to brush my teeth just to drive the kid to school or just to, there are certain things that you can definitely get away with for sure at the perimenopause and menopause ages. But even despite all of this coverage and awareness, I feel like so many women, or, I'm 51, my female friend group, we talk a lot about this subject and what is your doctor saying, or, and so I think it's great to continue the conversation. And I'm just so delighted that you're here to kind of walk us through some of these things. I thought we would start. I want to get into all the symptoms because, that's sort of how we all realize it or know that we are going through it, is when the symptoms show up. But could we talk about sort of maybe just at a high level for people who are not as familiar, maybe are some of the men out there who might be listening, about what is menopause technically, what is perimenopause, and sort of what are the ages of when those two things generally start?
Sure. So menopause is a natural transition that women go through in midlife that really marks the end of fertility. It's really when our periods stop and we're no longer able to reproduce. Just like every other mammal in the world, we have a lifespan as far as when we can actually, reproduce and create other mammals like our kind.
Yeah.
So when we have that last period, once a last menstrual period happens and 12 months have gone by since that last period, we can say that you're officially menopausal. Now, perimenopause is basically that time period leading up to that. It's when our hormones are changing, the ovaries are starting to ramp down their production of hormones, and it's all that time period from when your symptoms start and when that transition starts until that final period happens. So for some women, and for most women, it can be up to 10 years that you can be living in perimenopause. So it's kind of crazy when you think about it. But we could still be fertile and we could still be reproducing during that time too, but also start to have menopausal symptoms start to creep in. So it's crazy because women, the average age of menopause in the United States is 51. So if 10 years of perimenopause can happen, that means you could start at 41. Some women are earlier, and that's the average, right? So there's always going to be, like when you think about a bell curve, when you were in school and where the grades fall, there's going to be women that are younger than that, women that are older than that, but that's the average is 51. So,
Well, I remember I had a very close friend. She and her partner did not end up having a child, but they were going through IVF, and she was in her late 30s at the time, and she was not producing very many eggs. The quality of her eggs was not very good. And I was really surprised that that would could be happening in your 30s. And I know Naomi Watts, I've heard her story too, was a similar thing. She wanted to start having kids in her late 30s, and she was in perimenopause. I mean, her hormones were all over the map, and she was having all the symptoms, and was ovulating. I think maybe, I don't know if you ovulate less or you just don't have as strong
it's really
quality
about
of
the
eggs.
quality of the egg. So I think
Yeah.
not a lot of women realize that we are born with all the eggs we're ever going to have. They don't regenerate during our lifespan. So the most eggs we ever have is when we're actually a female fetus inside of our mothers. And then
Wow.
as soon as we're born, a bunch of them die off. Even before we hit puberty and before we start having menstrual cycles, more die off. And so when we start having our periods, an average age of, the first period is around 12, 13 for most women, sometimes younger, sometimes older. But then we start releasing an egg each month, and we ovulate each month. And that's why we have that whole cycle. We have menstrual cycles each month. But there's also like, death of the eggs just by attrition and by old age. And so by the time we get to our 30s, it's 30 years of those eggs dying and desiccating and so
God.
it's crazy. You don't think about it, but that's really the background of why our hormones are changing because we have the hormones to support those eggs, and when those eggs are gone, the hormone production really starts to decrease significantly. So,
So you brought up the big H word of hormone, and I think, I want to talk about one of the hottest topics right around perimenopause and menopause is hormone replacement therapy. And I think that there are some, at least from what I've learned from doing that episode last year, and kind of again because I am 51, it's all that comes across my my
mhm.
algorithm on Instagram. So I feel like I know, about it, but I'm here today to talk to you, the expert on it. But it seems like a lot of the controversy and concern or recommendations around the use of hormone replacement therapy has evolved or changed over the past,
Yes.
couple of years. So I thought maybe it would be helpful. I know too, this past summer in July, Dr. Marty Makary, I hope I pronounced that
Mhm.
correctly, who's the head of the FDA, gathered a group of experts to talk about
Yes.
menopause and menopause treatment. But for people, I have friends who either have a history of breast cancer or who've had history of breast cancer in their families, or they themselves are breast
Mhm.
cancer survivors who just automatically sort of dismiss hormone replacement as an option for them. And I think that was also based on a study. So I thought maybe we could talk about, if you would give a little more background about how HRT, really hormone replacement therapy, got a bad name or bad
Yes.
rap, right? And then what does science say today, and what are the recommendations for today?
hmm Yeah, absolutely. So I think, looking into the history of this, women really didn't get many treatments. Medical studies in women just really haven't been done. And even birth control wasn't really available until, the 60s, 70s for most women. And so back in like the 80s and 90s, there was a movement where many women were getting HRT and were getting hormone replacement therapy and doing very well. But they realized there weren't many guidelines and there wasn't much information about its safety. And so there was a big study that was done called the Women's Health Initiative study. And that finished in 2002. And basically, before it could really be peer reviewed and before it could really be scrutinized by the medical community, they ran with these results and things started to be releasing, in the news and press. And all these headlines started coming out about, the dangers of HRT. And they were taking some people say it was a bad study. It was actually a really good study. That was the first time they did a really large scale study looking at this in women. And now we've learned a lot of really good things from that study. But what happened was they took these headlines and like little snippets of information from the results of the study and went rampant with it in the news. And so suddenly there was this mass fear produced as a result of this study where everyone said, oh God, this is really dangerous. I'm going to pull all my patients off of it. So literally nationwide, doctors were stopping HRT, women were throwing away their HRT, and they weren't really looking at the big picture. So that really swung the pendulum. And then suddenly in the early 2000s and thereafter, no one was getting HRT. It really wasn't made available because of the fear. And it was really the fear of, is HRT going to cause cancer? Is it going to cause somebody to have a blood clot? And what we learned about that study overall is that there is a magic window of time where it's the safest to start HRT. And the women that were at higher risk were the ones that were started at a much later age than really would be safe to start somebody, after age 60. After you've been through menopause and you've been menopausal for more than 10 years, it can be more dangerous than good to start you on hormones, at the first point in your life, 10 years after you've completed menopause. So really, we're still fighting that stigma and all that negative press that came out of that study. But now more and more information is coming out, and now there's more of a call for research, and more studies have come out actually showing its safety and the benefits of HRT. So, I think what women have to realize now in the data, like if you anybody can watch that FDA panel that was convened in July, it was excellent. They took some of the world's, experts on HRT, and they had basically a short amount of time and they had one slide to be able to present, but they really presented some really great information about the risks and benefits of the medication and really the long-term benefits of it and how it can protect our bones as women, how it can really protect our hearts. Because I think there's this widespread panic and fear about getting breast cancer from taking hormones. But what women don't realize is that more women in America die from heart disease and heart attack every year
Right.
than ever die of breast cancer. So we have this like really unfounded fear of breast cancer. And thanks to the Susan G. Komen Foundation and all the press that breast cancer research has gotten and all of that, there's a lot of knowledge about it. But I don't think women realize they're much more likely to die of a cardiovascular event like a heart attack or a stroke than they ever would be to die from breast cancer.
Yeah. So going back to that women's health, it's the Women's Health
Yeah,
Initiative study.
WHI, we call it for short, the Women's Health Initiative. Yeah.
That test group or that group was generally over 60 getting HRT or starting HRT a little bit later. And that was sort of why it probably isn't a great indicator of how people would be reacting to HRT at younger ages,
Yes.
right?
And the other thing too, what we know too, like as menopause providers now, the medications they were using in that study were synthetic forms of hormones. So they were using conjugated estrogens, which, one of the oldest medications like Premarin, which is actually a conglomeration of estrogens, some of which are not even biologically active in human females. So, the Premarin word actually comes from pregnant mare's urine. The first time they got that drug, it was actually from, extracting it from the urine of pregnant horses. So there
Wow.
were horse estrogens in that drug for a long time. And so what we know now is that if we give women what we consider to be bioidentical, meaning that the hormones we're giving them are the same hormones that their body was producing on its own when it was producing enough. Like we have
Yes.
3 estrogens in our body as women, as human women. It's estradiol, estriol, and estrone. And anything other than that is a synthetic form. So, like when we take birth control pills, those are synthetic forms of estrogen. Also, the progestin that they were giving, which is a form of progesterone, were synthetic progestins. So when they were doing the WHI, they were giving a lot of synthetic medications. Where now the push, with medications now, especially with giving hormone therapy, is to give the same exact molecule that our body was making on its own. It seems like, it makes more sense to give your body back what it was making on its own so that it can be more efficient in utilizing those hormones because it's
Right.
already familiar with their shape and their structure. Like if you think back to like high school chemistry, you know, when you think about a synthetic medication, it's very similar, but it's not the same chemical structure. So your body might not be able to utilize it as much. So you end up having to use a higher dose to achieve the same effect as whereas if you give the patient back a hormone that they were creating on their own, their body's more efficient in utilizing it and incorporating it into the system.
That is fascinating. I mean, I have a patch. I'm patched and creamed from stem to
Me
stern,
too.
really, these days. I feel like and I think I'm on estradiol.
Yeah.
So is that enough, or are the drugs being even further refined where they're providing you with all three types. Is that what you're saying? There are three different types
There's
of
three different
estrogen,
types that
so
our
I'm
body
only
has,
getting
but
one?
estradiol is like the powerhouse. Like that is the most biologically active estrogen in our body, and it does most throughout our body. So being on estradiol patch is perfect. That's exactly what you need.
With that initial study, some of the conclusions that were made were sort of flawed in that it doesn't reflect the sort of the whole population. So that's one
Right.
issue. And then what about though, is HRT more of a risk factor for people who do have a history of breast cancer or are breast cancer survivors?
So it's really if you're a survivor yourself, right? So if you
Okay.
have, and it's not just breast cancer, but if you've had any kind of female related cancer, whether it be breast cancer, ovarian cancer, uterine cancer, the only one not incorporated into that is cervical cancer because it's typically related to the human papillomavirus, which is sexually transmitted.
Okay.
But any of the other forms of female cancer, if you have a personal history of those cancers, there's the potential that taking hormones of any kind, whether it be a birth control pill, whether it be hormone therapy in menopause or perimenopause, could feed any residual tumor that could be left in your body. Because especially with breast cancer, you might have heard like a ERPR, it's estrogen receptors, progesterone receptors. Like some of the tumors actually have receptors for those hormones. And so if you take in exogenous hormone, meaning hormone that's not made by your body, then it could feed tumor tissue that's still lurking in your body. So that's a conversation, it's not that it's completely contraindicated, but you're at higher risk if you've had a personal history of cancer. It's not the same though as having a family member with cancer. So just
Okay.
because you've had other women in your family that have had breast cancer does not mean that you're not a candidate to take HRT. Really, we look at many different factors, and now we have genetic studies that we can do to see if you're a carrier of the breast cancer gene, the BRCA gene. So if somebody has a genetic syndrome that increases their risk for breast cancer, they're at much higher risk than the average population. But other than that, if you've had a grandmother or an aunt or someone else with breast cancer, you could still be a great candidate for HRT personally. Just having a family member does not increase your risk that significantly. But it's really a personal decision that a lot of women have to make, right? So, when you're going to see your doctor and you're going through this and you're writing down your symptoms and you're trying to figure out how best to treat yourself and how best to move forward, it has to be an intense conversation and some shared decision making, talking about what your risks are, what the benefits are. Anytime you make a big decision, you should think about the pros and cons. And each woman has to make that decision for herself, I think, in weighing the good, the bad, and determining like what is worth the risk or not.
Right. And it's interesting. So just for people who are maybe gene carriers, they also might be in the same boat as someone who was a cancer survivor. But
Right.
those are things, as you're saying, you really need to get into the weeds with your doctor about and weigh the pros and the cons.
Absolutely.
So with sort of this evolved thinking around it or new science around it, has the FDA changed its recommendations or warnings on some of these drugs
Not
or
yet, but that's what
okay.
the FDA panel was really calling for that. So, one of the biggest things during that FDA panel was that they were talking about vaginal estrogen a lot and systemic estrogens. But the main thing is, even if you've had a breast cancer, you have a higher risk for taking systemic hormone, meaning that hormone that goes throughout your entire body, you can still be a candidate for vaginal estrogen because there's a significant set of symptoms that happen to us in menopause called genitourinary syndrome of menopause. Used to be called atrophic vaginitis or vaginal atrophy, but really it can include, the changes to the vagina, like our vagina gets dry, we lose lubrication, but also the tissue around our urethra and our bladder loses support, so we get more risk of, incontinence and urinary tract infections, things like that. And what happened is they took the big black box warning that's on systemic estrogen that talks about, if you take this medication, it might increase your risk of having a heart attack or stroke and this and that. It's like a very fear mongering little box that's in the like pharmaceutical paperwork that you get when you get your prescription. And they put that same black box on vaginal estrogen when it absolutely does not apply to vaginal estrogen. Vaginal
Interesting.
estrogen we give topically to help support the vaginal tissues, but it's typically only locally absorbed, not systemically. So it really only gets absorbed in those tissues down there in the vagina, the vulva. And so it doesn't increase your risk of having a blood clot or stroke. It really doesn't increase your risk of those other things. And so they were really pushing for in that panel, like, let's get rid of the black box warning on vaginal estrogen. And so those things take time. The FDA had that panel, and then they had like an open forum where you could go onto the FDA's page and you could either write and support or refute, what they were trying to recommend as far as removing that black box, and just make commentary on the panel. And what they're going to do is they're going to look at all that information, get more information from the experts, and then they'll decide if they're going to make changes. But the menopause community of providers, across the country, we're really hoping that they make change, because the worst thing is when I recommend something for a patient and I order it, and then they get the packet and they get home and they read that black box and they're like, Dr. Brown didn't say I was going to do that X, Y, or Z,
Right. Right.
and then they lose trust in me because they see that black box warning. And I try to explain to them it really doesn't apply to this product, to vaginal estrogen, but they don't understand. They just see this paperwork they got from their pharmacist. And then we also have the problem with the pharmacist then fear mongering and perpetuating a lot of the fears and a lot of the unfounded warnings about HRT to patients. And so the patients then are confounded. Like, they're like, well, who do I believe? Who do I trust? They want to feel better. They're desperate to feel better. But when you get that paperwork, any paperwork you get with your medication, if any of you have ever read it, it's scary. It's very
Yeah.
scary. And
How
it's
about
not
the
only
commercials
Botox.
when people are like, you'll be bleeding from your eyes? And I'm like, no, I don't need to take that for itchy skin or whatever the thing is. But
Right.
that is, you're hitting on something though with the pharmacist, and not all healthcare is created equal in this country. And some doctors are constantly reading new papers and learning more. Others are perhaps, have been practicing for a long time and feel like they don't need to be as sort of on the forefront of the new science. But what's dangerous about that, or what's frustrating about it, is then you have situations where, your patient gets home and says, oh gosh, I don't want to have a higher risk of cancer because I'm using vaginal estrogen, which, to your point, shouldn't even be,
Shouldn't even be in the paperwork. Yeah,
right,
exactly.
related. But
Yeah.
I'm glad the FDA is taking a lead on that, because I think with that shift, then there will be that trickle down where everybody seems to follow the FDA,
Yes.
recommendations generally, right?
Generally, yeah. And we look to, I mean, as a group of people, we look to these bigger organizations to help to reassure us that things are safe, right? Generally, you'd like to know that something you're taking has been vetted by this greater organization that's supposed to be making sure that you're safe. And so a lot of patients, I think, are kind of waiting for that. And I think a lot of doctors are too. But the problem is that it takes some time. Sometimes they are not up on the latest science. And so that's the importance of why they had that FDA panel convene, because it really was a great venue for them to talk about the latest and the most critical current information of what we know about hormone therapy and its
Yeah.
safety. Yeah.
So we talked about the vaginal estrogen. I know because I have some of these things. I have my progesterone and I have my patch. I also went to an endocrinologist for something else, and she was saying that my testosterone level was so low, you know, so she gave me some testosterone cream
Mhm.
that I put on the back of my knees, 3 days a week or whatever it is. Should women be getting a full panel to get all their hormones checked at what age? And then what different types of hormone replacement are kind of out there, and how is it customarily administered?
Yeah. So the most important thing that I can share too is that when it comes to lab test, if you're considering testosterone treatment, that's the only lab test that typically that we use. Is when you're replacing testosterone, you have to check levels to make sure it doesn't get too high. But for the average woman going through
Because you get road
perimenopause,
rage or a
yeah,
beard. I mean, yeah, okay.
yeah, you don't want to grow facial hair and your voice
Right.
change, and there's masculinizing side effects that can happen if you get too much testosterone. And that's another thing the FDA panel talked about too back in July, is that we do not have an FDA approved product or medication to be able to offer to women at all in the United States. So the cream that you're using is actually a male product. It's FDA approved only for men. And so it forces doctors to have to extrapolate and kind of do the guesswork of trying to figure out what an appropriate dose is for a woman, because they don't have an FDA approved product of testosterone for women, even though women have testosterone too. I don't think a lot of women realize that. Like, we have our female hormones, we have estrogen, we have progesterone, but we also have testosterone circulating in our body. It's responsible for a lot of other functions in our body, like our libido, our metabolism. It really has a good effect on our muscle maintenance and our energy level, things like that. And I think a lot of women don't realize, they're like, well, I'm a woman, I don't have testosterone. But
Yeah.
no, you absolutely do. So, but when we're talking about perimenopause and menopause, getting hormone levels really is not helpful. So, actually, the guidelines from our Menopause Society and also the American College of OBGYN do not recommend getting hormone testing routinely. There's no test that we can order that can tell me when I look at the results, like when I could guess or predict when a woman's going to go through menopause. It doesn't tell me how best to treat her. It doesn't tell me what dose is going to be helpful. So it really is not very helpful information. What's actually more helpful is to start doing symptom tracking. So for women, it's about, learning what are the common symptoms of perimenopause? What are the things I should be looking for? And tracking those things over time. Because as a menopause provider, that's the information that's much more important to me and much more useful for me to know. Because I can look at a woman's list of symptoms and I can tell you, okay, these symptoms are happening because her estrogen is dropping. These symptoms are happening because it's more of a testosterone issue. So starting someone on treatment, you really don't need to do any labs. And even after starting HRT, if you're starting estrogen and progesterone, and the reason why you need both is basically whether or not you have a uterus. So for most of us, the treatment we need as we go through this transition is estrogen. But if you still have your uterus in place, meaning you have not had a hysterectomy, the progesterone is added in mainly to protect that uterine lining, because estrogen is so beneficial throughout our entire body. But the one really negative thing that it can do is it makes that uterine lining overgrow or fluff up, kind of like a shag carpet. And that can lead to cancer if not checked and not regulated. So progesterone's main function, and it can help a little bit with some of the other symptoms, but its main purpose is to keep that uterine lining nice and thin while you're taking estrogen. So,
Interesting.
yeah.
So you'd want to test your testosterone levels as a female
After you start treatment, mainly to make
after
sure
you
that you're
start.
not getting in a dangerous zone.
Are there zones, like for cholesterol, for example, and I've, learned, I just play a doctor on TV. I learned this from, but my kids are like, would you get this from Instagram too? But I know that, there are what doctors will say normal range, and then there's optimal range.
Mhm.
Is there such a thing for, I know you just mentioned estrogen and progesterone, rather, don't have, you can't, looking at those levels isn't going to really help you. You're really looking for the symptoms, right?
Right. Right.
But with testosterone, are there like sort of healthy ranges that doctors kind of will know? I mean, my doctor did say, I can't remember what mine is. Mine is like, she almost was surprised I'm standing up because my testosterone was so low. And I do feel, by the way, better, a bit more energized by being on it
Mhm.
than I was before. But are there optimal ranges for testosterone? Is that something we should
I mean,
be?
there are, and there's different studies that have been done that have come out with a chart for, where women should be. But again, this is kind of like a call for more research and more information, because most of the charts out there for normal testosterone levels are for men. There are
Right.
some for women too. But every lab, anytime you get your levels done, like if you're going to a hospital or you're going to like a separate lab place, they had all set their own levels for everything, whether you're getting a blood count or a chemistry level, getting your liver function tested. Every place that does labs has their own ranges and their own, parameters that they look for. So, and some of that's based on, papers they get the information from, some medical. When it comes to medicine textbooks, by the time it gets published in a textbook, it's really old information. So most of the time we look at research studies that are in our medical journals. And, one of the things that we have to do as physicians is to do continuing medical education. And so there,
Yeah.
you have to constantly stay on top of that. And most specialties have that requirement where you have to continue to do, basic education each year to stay up to date. So, I mean, there are levels out there, but it's going to vary. Like, I wouldn't want to say a number, because then if you go to
Right.
your lab and somebody listening is going to their lab and their number is somewhat a little bit different, because their lab parameters are a little bit different for the assay and the specific tests that they're doing at that lab.
But there is a guideline, so it's not
Yes.
totally the Wild West on the
No,
testosterone front.
no. What they're looking for, what it is that they're going to do with the information when they do get the labs. And so there's going to be some doctors that don't feel comfortable doing levels of anything. If they're not somebody who's prescribing testosterone, they're not going to be as familiar with looking at testosterone levels. But it's one of those things where if you go to your physician and you're bringing up the fact that you're feeling awful, you're feeling fatigued, your periods are out of whack, you're starting to talk about all the symptoms of perimenopause or menopause, and maybe you're still having cycles, but they're only coming every 3 to 4 months or every 6 months or something like that. And you're going to talk to them about what's happening and they don't want to hear it, or they tell you, well, this is normal, or you're feeling down and you're feeling moody because you're depressed. Here's an antidepressant. It's so common that women are just kind of like shushed and kind of told, well, this is a normal part of your life and you get used to it. But when we're going to them and we're telling them, like, I don't feel well, I am not
Yeah.
functioning like myself, I don't want to feel this way. This is affecting my work, it's affecting my family, my relationships, my interactions with people, and I just don't feel like myself. A lot of us that are going through this transition feel like it's like an out of body thing. It's like we are
Yeah.
not ourselves. If your doctor is not receptive to that, and if you're not seeing a doctor, say you're seeing another provider like a PA or a nurse practitioner, don't be afraid to just come out and ask them, are you comfortable talking about this? Do you have the experience with dealing with patients with this? And if they get offended, that's your answer right there. They should never get offended. They should be open and say, you know what, I don't really have much experience with this. Then ask them, well, who would you refer me to? Like,
Right.
you have somebody that you refer patients to for this. And if they don't, that's exactly why, like, our platform, Winona, exists. We exist for people that do not have access to a doctor in person who's willing to help. Or maybe they live 3 or 4 hours from their doctor and it's just a pain in the ass to really drive all that way to go in to get seen. But I think that, as patients, what we have to remember is that we navigate our care. This is our body. We only get one of them.
Yeah.
And we have to take the best care of it that we can. And if we're not getting the answers that we need, you got to be that squeaky wheel. You got to demand better. And you have to push for the care that you need, I think. I think we have to remember that.
Taking a quick break here to tell you a little bit about my latest sponsor, Karun. I am a huge fan and customer of their products, and I promise once you see their things, you will be too. Karun is a contemporary travel brand with the most beautiful custom bags, hand-painted bags, totes, luggage, travel accessories, and more. They even have gorgeous mahjong mats that you won't find anywhere else. Their products are made of the finest Italian leather and canvas, and Karun really harkens back to a bygone era in their design of travel and exploration. Their products make the best hostess presents, birthday gifts, thank you gifts, particularly because they can all be personalized with someone's monogram or their pet or any creative thing that you come up with. You may have seen some of Karun's products on celebrities like Jennifer Aniston, Jennifer Garner, Reese Witherspoon. The list goes on there, and of course, they're also among Oprah's very favorite things. And what's more is Duolog listeners get 20% off of any Karun purchase. Just go to their website at www.karun.com. Karun is spelled Corroon, so it's CORROON. And just enter the promo code Duolog when you check out for 20% off. Trust me, you will not be disappointed. Well, I had my own experience. I go to it. I adore her, a very highly regarded OBGYN, now just GYN in New York City. But I was having symptoms years ago, moodiness, hot flashes, sleep disturbances. And her solution was, she said, I wasn't a candidate for HRT because I was still getting my period and all this stuff. And anyway, I since went to a menopause specialist. I'm on HRT, and it's like it's been a new world for me the past 2 years.
And
A
that's
new
another
world.
thing. That's another fallacy that a lot of people out there believe, is that if you're still having periods, there's no possible way you could be suffering from menopause symptoms. And that's just not true. Because until those last few eggs die off and until our period completely ceases, there's symptoms starting to happen as our levels are changing and our hormones are dropping. And that's what a lot of doctors feel, that way, that they're not safe to prescribe to you. But for some women, by the time your period actually stops, it seems like it's too late because you've already been suffering for years with symptoms,
Yeah.
you know?
And the suffering is real. I mean, it is real. I remember my mother being like, I'm having a hot flash. And I thought she was being dramatic. And I have some newfound patience and respect for some of the
Yeah.
things that she went through, having gone through them myself. But just quickly before we move on, because I want to talk about the benefits of HRT and then all the different side effects of menopause and stuff to look for, is there any alternative? And I had read, I think I could that the FDA is looking, or they've recently approved some drugs to help people who are in a high risk category with
Yes.
some of the symptoms. Can you
Yeah.
talk
So
about that?
yeah, there's a new medication out that's called Veoza, which is a medication that works in the brain, actually on neurotransmitters in the brain to really help with hot flashes. And
Okay.
what we consider hot flashes and night sweats, they're in the category of what we call vasomotor symptoms. It's basically your body is unable to self-regulate its internal thermostat. And so these can be triggered anytime. They can be triggered by stress, they can be triggered by alcohol, various things, but also they can just happen haphazard too. So if you're someone who has had a history of breast cancer or ovarian cancer, and say you're in that higher risk category where hormones might not be the best option for you, then this is an alternative to help with some of those symptoms. The downside is it doesn't give you all the benefits that taking estrogen can give you as far as for your bone health. It won't help with brain fog. It won't really help with some of the other mood symptoms. It really only addresses those vasomotor symptoms like the hot flashes and night sweats. But it's the first thing that we have in a while that's a good alternative. We've had other non-hormonal forms of medication that we could offer patients for symptoms over the years. Some of them, we can use antidepressants, which can sometimes in low doses can help with hot flashes. There was also an old blood pressure medication that was a really old school medication that would also help with hot flashes when given to patients in this time period too. And there's a seizure medication that we use. It's used for things like chronic pain, for seizure disorders, but that has also been shown to help with hot flashes and night sweats too. So we had those around for years that we would use, but this is like the first, the Veoza is the first medication we have that's new in a long time that's a non-hormonal alternative. So it's nice to have another option.
Yes, for sure. For people that think that they just have to suffer in silence, there may be another non-hormone medication that they can take that could help alleviate some of the symptoms. Okay, you mentioned a little few things. You mentioned cardiovascular disease
Mhm.
and I think osteoporosis, but let's talk about all the exciting positive effects of hormone replacement
Yeah.
therapy.
Absolutely. So really when you look at estrogen, it's really like the powerhouse hormone for a woman's body. So estrogen really affects our skin and all of our tissues. It helps to maintain their hydration, helps to keep skin and hair and nails healthier. So a woman who has high levels of circulating estrogen, her skin is more supple, it's more moisturized. And so when we lose estrogen, you get this dryness. The skin gets thinner, actually. We lose like the thickness of the skin, so the elasticity also. So that's one of the benefits. There's like anti-aging benefits, right? So if you have continuing good levels of estrogen in your body, those negative changes that happen with the loss of estrogen decrease significantly. Also, it's, for our muscle health and our bone health, keeping the bones healthy, keeping estrogen circulating helps to keep the bones strong. We also have to do our part as women. It's like going on medications and going on hormones is not like a magic bullet. You still have to do the lifestyle changes that you need to take care of yourself. Like I said earlier, like we have this one body. We
Right.
have to take care of it the best we can. So part of doing that too is that we have to maintain our strength, right? So we have to do as much activity as we can and finding a way. Like I think that so many of us feel like it's an all or none thing. Like if you're not the perfect gym body, going to the gym so many days a week, doing everything perfect in the perfect little gym outfit, that it might not even be worth it. But that's not true at all. It's just finding moments of movement, like taking the stairs for a couple flights at work instead of taking the elevator, parking further away from the grocery store and walking a little bit more of a distance rather than parking right up front or getting an Instacart delivery or something like that. If we find like these moments of like 10 minutes, 15 minutes of walking or adding things into our life, it has tremendous benefits for our heart health, but also for our strength and our bone health and our muscles. And I think the other thing too that women have to realize is they need to do weight bearing or resistance exercises. We don't want to be those little old ladies that are frail with our like,
No.
the little hump on our back, and we don't want to fall and break a hip, and it can be devastating. And really, you want to maintain that health and vitality. And so we have to do that with like our nutrition and our exercise, but also keeping estrogen circulating in our body helps to keep those tissues healthy as well. So
Interesting.
on that FDA panel, they actually had an
Yeah.
orthopedic surgeon, Dr. Vonda Wright, who's wonderful. She's another good person to follow on Instagram. Really great information. But she was pushing the FDA to really give more recommendations for estrogen and on the safety of estrogen, because she really, in her case, was she wishes she didn't have to put so much hardware in women who are falling and
Yeah.
breaking a hip, who have no bone structure when she goes to try to repair it. Like she tries to repair fractures of women that have fallen in older age. And because of the loss of estrogen, The bone has lost its framework. It doesn't have any strength. And she's putting so much hardware and metal into women unnecessarily. When if they had taken estrogen and taken hormone therapy, it could have been preventable. Their bones would have been healthier. And that was a big thing, to see.
Oh, yeah. And also, you mentioned heart health and organs and all those things. We've all been told, and that the science shows that women live longer than men. But what I wasn't, in terms of years, I didn't understand until I've, again, getting all my information from Instagram, that women don't lead the same quality of life that men do, meaning we're more likely to fall and break a bone, to be in a walker, to just have a limit. And, again, I'm just play a doctor on TV, but I was thinking to myself, gosh, the big differences between us are that women go through this change that men don't. Men, maybe they lose some testosterone as they get older, but it's not this dramatic shift to their body that we all experience. And there has to be some correlation, right,
Yeah.
between, the frailty and lack of hormones, cardiovascular disease, lack of hormone, all cognitive decline. That's another big one.
Absolutely. Yeah. Absolutely. Because when you look at cognitive decline and, dementia, women are at such higher risk of developing that and developing Alzheimer's disease than men. And it really has been linked to the loss of estrogen in the brain. Estrogen is critical for the creation and the function of a lot of neurotransmitters in our brain, which is why when our estrogen falls, we have mood changes, we have
Right.
cognitive decline, and issues with memory loss. It's so common in midlife, and I see it, and my kids have made fun of me for it because like sometimes I go through every single one of their names before I get the right one. you know or you go into a room to do something, and by the time you get there, you're like, what did I come in here
Oh,
for?
yeah. No, my 16-year-old just came home for a long fall weekend from his boarding school, and if I had a dollar for every time, he's like, "Mom, you need to get an MRI." I'd come out of the parking lot at the grocery store. His brother, I'm like, "Where did we park?" I mean, all these things that, he was totally freaked out by my memory gaps, but it is a real thing. Okay,
Yes.
one other thing though, I have a question about the estrogen, progesterone before I switch to all the symptoms that you want to look for and then how you can treat them. If you were prescribed estradiol or progesterone and it alleviated your symptoms, and then a couple of years goes by and you're experiencing some symptoms again, is that the time when you want to go back to your provider and saying, I'm having hot flashes again, I'm having
Yes.
sleep issues again?
That's a sign that your estrogen dose needs may have changed. And that can happen
Okay.
because maybe your body, when you first started treatment, maybe your ovaries still had some eggs and you were still producing some of your own estrogen. And then as you age, that continues to decline. And so as you get older, you might need a higher dose to maintain those symptoms. The other time it can happen is if women they gain or lose a lot of weight, that can also change your estrogen metabolism in your body, because one of the forms of estrogen that we have, our estrone, is stored in fat cells. And so if you lose a significant amount of weight, which a lot of women are doing now with all the GLP-1 medications, and
Yes.
everyone's getting fit, but if you lose a lot of weight, it may change your estrogen needs too, because you no longer have that increased level of estrogen circulating when you were heavier set. And so those changes can happen. But anytime you have a change in your symptoms and you're on treatment, you definitely want to have a conversation with your doc who's prescribing and just let them know. Like, I was feeling great, but over the last month, I'm starting to notice like more and more hot flashes, more and more night sweats. The other symptom that a lot of women get a lot that'll come back as their estrogen dose needs change is like body aches, muscle aches, things like
Mm,
that too.
yep.
Yeah.
Okay, let's go. This might be like a I'm mindful of our time here, your time particularly, but some of these symptoms,
Mhm.
right, that could mean that you might be in perimenopause, think something to talk to your doctor about, but in your experience, what is the best way to address them? Because I'll start with the most common one that you hear around menopause, which is hot flashes.
Yes. So hot flashes actually for most women happen later in this process than many of the other symptoms in perimenopause. So by the time you're starting to have hot flashes and night sweats, you've already had some other subtle symptoms that maybe you didn't recognize. But when you start to have hot flashes, one of the things you have to look at, even before thinking about medication, is what's your hydration status? How was your sleep? Sleep is one of the other big symptoms that a
Yeah.
lot of women start off with. So, starting to have sleep disruptions in perimenopause is one of the first things that a lot of women really start to complain about. Maybe trouble going to sleep, trouble staying asleep, waking up too early, waking up many times in the night. And sometimes it might be that you wake up in the middle of the night and you don't know, is it because I had to get up to pee? Is it because I had a night sweat that woke me up? Or am I
Yeah.
just not able to stay asleep more soundly? But all those things, like if you try to do everything you can to optimize your sleep and it's not getting better, your experience of hot flashes and night sweats is going to be worse. Our body, our human body needs a normal sleep wake cycle in order to deal with all the things that are thrown at us. And so if you're not sleeping well and you're not getting good quality restorative sleep, you're not going to do as well and you're going to have more symptoms actually. And I know that from experience, just being an OBGYN, doing 24-hour call shifts. Every
Right.
time I had been awake throughout my career, even when I was 20 doing overnight shifts and working 36 hours straight, when you are sleep deprived, your internal thermostat, your thermoregulation does not work well. I used to have hot flashes back then just from being sleep deprived for a couple days.
Interesting.
Yeah.
Okay.
So it's something that though you really have to focus on. And I think that, you know, we need to focus on quality sleep. I think that many of us would get through much of our health struggles and a lot of the things, and especially midlife and in the transition of perimenopause and menopause, we would deal with a lot better if we could get better sleep. And if we really gave ourselves the luxury of getting 8 hours a night, that would be wonderful.
So, but if you're having those sleep disturbances and you're having hot flashes, HRT is probably like, besides working on your hydration and trying to be very intentional about your sleep schedule and those kinds of things, if it's a big shift for you and you're all of a sudden like me up at 2 in the morning on looking at reels from 2 to 4 in the morning, now it doesn't happen to me. I mean, occasionally it does, but not, now that I'm on HRT, it's a new world. Is that, those are the two things you'd recommend?
Absolutely. I think
Okay.
HRT could help tremendously.
Mood swings.
Mood swings too. And now, and this is so common. Mood swings are something that a lot of women experience, but if all of a sudden, like the mood swings are extreme, like suddenly, maybe you've been happily married for 20 years and suddenly you're looking at your partner thinking, why am I married to them? Or you're
Yeah.
contemplating like, or, you're just your tolerance, your resilience and your tolerance for other people or their behaviors goes really down. We just can't roll with things as well as we used to. But also just large, fluctuations in our mood is very, very common with the ups and downs of the hormones as they're occurring, in this perimenopause transition for a lot of women.
So I don't practice anymore, but I was a matrimonial lawyer. And
Oh,
I look back at some of my clients that were in their 40s, and it would just be like, I just can't look at him anymore. And now I'm thinking to myself,
it
oh
makes
my
sense,
God,
right? It
maybe
makes
she just
total
needed a
sense now.
patch. Yeah,
Right.
maybe she just needed a patch. Oh my gosh. So anyway, okay, so mood swings, HRT, or if you aren't a candidate, maybe an SSRI or
Yes, yes.
some of these other things that will help with mood balance. Vaginal dryness, loss of libido.
Yeah, vaginal dryness is a big one, and vaginal estrogen is by far the best treatment for that to help restore the vaginal tissues to their, prior state and help with the suppleness and the tissue health itself. But there's also if you're afraid of doing that or if you just maybe you can't get into the doctor, there's other things you can buy over the counter like, vaginal moisturizers, things like that that you could try. When it comes to like loss of lubrication, like maybe you have the desire for sex, but when you try to go have sex and you try to be sexually active, like your body doesn't respond the way it used to. Like you don't get wet, you don't have that lubrication naturally. So lubrication is really important. There's a lot of different kinds on the market. That's something that can help. But for women that actually start HRT systemically for the other symptoms, they start to notice that their vagina starts responding like it used to when their levels are better. But also vaginal estrogen can help with that too.
Well, I just saw literally yesterday. I wonder if my Instagram heard me talking about the fact I was going to be talking to you today, or I don't know, or it's just what's always on my feed. And it was Dr. Mary Claire Haver was on some podcasts talking about how you want to have vaginal estrogen just for the suppleness of the tissue.
Yes.
So my question for you was, even if you don't have vaginal dryness because you're on a patch or something, do you want to also supplement with that just to sort of taking care of the skin there or
Vaginal estrogen for women that don't need it for symptoms, sometimes the reward of it may not be worth the risk because it's messy. You're getting an applicator, you're filling it with cream, and you're inserting the cream into the vagina, and so what goes up must come out.
right, right.
So, typically we tell you to put it in at bedtime because then when you're laying horizontal in bed and sleeping at night, the cream maintains the most contact with the vaginal tissues and more of the hormone gets absorbed. But once you're up and vertical in the morning and you're moving about, the vehicle cream, once the hormone's been absorbed, there's still cream left behind. It's not that it doesn't,
Okay.
it's not that the hormone is not getting absorbed. It's there's a vehicle that the hormone has to be delivered through, but you'll have a discharge the next morning. So for some women, they might not like that. So if you're not dealing with vaginal dryness directly, sometimes you might not want to deal with the messiness of vaginal estrogen, but a lot of my patients do both systemic and vaginal and really like the results they're getting. You will get some benefit from being on systemic estrogen, for the vaginal tissue, but if you're to the point where you're already noticing a significant amount of symptoms, vaginal estrogen will be by far the heaviest hitter for helping those symptoms faster and helping those the dryness get better over time.
And I probably should have asked this of you earlier, but what is so let's say you're starting HRT because you're symptomatic, right? You then go through actual menopause. So you've had a year where you don't have a period. After that, how long can you be on hormone replacement? Can you stay on it forever? I mean, if you stop taking it, are you going to go back to having those hot flashes, sleep disturb, all those things that come along with it? Or
Yeah, so this is a great question. And I get this question from patients pretty much every day. Years ago, we used to tell women that you should be on the lowest dose for the shortest duration possible, just because of the risk and from that WHI study. But now, more and more women are deciding to stay on HRT long term because of the health benefits that estrogen affords their body long term, as far as longevity and maintaining their body's vitality and strength and health. But for the average woman, I would say most women that go on HRT are on it maybe 4 or 5 years, and then they decide, well, they don't want to be on a bunch of medications and they try to wean off. And some women might get some rebound of symptoms. And if that's the case, they might choose to go back on. But a lot of women will stop and they do just fine. Really, when we're having the worst of the hot flashes and the night sweats, they're happening because of the wide fluctuations in our hormones. Like one
okay,
day you might release a lot of estrogen, the next day you have none. And it's that roller coaster of hormones that actually gives us the bulk of those symptoms, especially those vasomotor symptoms. So over time, those will fade. And so some women decide they want to go off of it just because they want to reduce the amount of things they're having to take every day. Or maybe they develop a medical issue that then makes the hormones a little bit higher risk, and so then they
right.
have to kind of reevaluate their life and reevaluate their medications to determine what's worth keeping versus not. But I'll tell you, when you talk to female OBGYNs in our demographic, which I'm in that group, women that are in this field that are reading the research and that are looking and seeing all the benefits of HRT, and we're dealing with patients with this, I'll tell you, you will have to pry my estrogen out of my cold dead hands because I don't want
Yeah,
to ever stop it. Like it has made such a difference in my own life, and I see what difference it makes in my patients' lives that unless there's a real compelling reason for me to have to stop it because of another medical issue, I'm not going to go off of it. I'm going to
yeah,
stay on it forever.
yeah, 100%. And I have some friends who are sort of say, "Oh, well, I can manage the symptoms and I'm doing all these natural supplements and things," which terrific, not taking that away from them. But then I also say to them, you might want to consider it for your bone health and your organ health and your, heart health and your cognitive health, all the other pieces of it, not just mitigating some of these perimenopause symptoms. Okay, hair loss
Mm,
is on the list. We're in Winona telehealth session right now, and I said, Dr. Brown, I'm losing my hair.
yeah.
Would you say Rogaine, oral minoxidil, HRT, combination of all? What's sort of in your wheelhouse there?
Typically, HRT can help to a certain degree, but there's also a lot of different things that can affect hair loss. And so, minoxidil is something that we know can significantly help. You can take it orally, but there's more risk of doing that, especially because it gets processed by your organs. And so, there's more of a risk involved with that. So, there's also topical minoxidil that's prescription strength. And we actually do offer that at Winona now, too. We had so many patients coming to us, with the hair loss issues that our pharmacists actually developed their own formula. So now we have a prescription strength hair serum for hair loss addition, that women can take in addition to their HRT. So that's something that, that I typically recommend for patients.
That's terrific. Okay, the
Yeah.
next one, weight gain and menobelly, which
Mm,
is real, real.
absolutely. It is real. a lot of times for women, this comes because our body is in a high stress state when we're going through these changes. When we're hitting midlife and we're going through all the symptoms of perimenopause, suddenly our body is in this like fight or flight mode. Your cortisol levels are high, you're in a high stress state. And so what happens is your body tends to want to absorb and keep calories. It doesn't want to burn calories. It doesn't matter if you're eating low calorie diet or working out all the time. Sometimes, despite all your best efforts, you still will have that weight start to accumulate in the middle. And it's because of that hormonal environment in our body with the cortisol levels being high or estrogen levels dropping. So for some women, getting on HRT and getting their symptoms under control and getting out of that high stress state goes a long way. And then suddenly all the other efforts they're making with diet and exercise start to do what it did before in the past. And so it helps with, weight management. There's some women that, no matter what we do, we might optimize our hormones by going on HRT and might feel better with all of our symptoms, but we still struggle with the weight. Some women go on medications for weight loss. There's great medications for weight loss now too. And now the data is telling us for women that are actually in perimenopause or menopause that are on HRT that also then decide to go on a weight loss medication like a GLP-1, they can be synergistic, meaning that the medications work together and women actually lose more weight being on the combination of the two than even being on a GLP-1 by itself.
Wow.
Yeah. So that's something we're learning a lot about. There's more and more coming out in the literature about that. And there's, added health benefits we're seeing from the GLP-1
Oh my
medication.
gosh. I have interviewed an expert on Alzheimer's and then a cardiologist, and they both were so excited about the new research that's coming out around the positive effects of GLP-1s
Yes.
for heart health and for cognitive health. And I don't know if it has to do with reducing inflammation or just keeping your sugar levels, just sort of that all that science around not having big spikes in your sugar levels, throughout, because that's part of what it does, right? It sort of manages
Yes.
those cravings and those spikes, so it's sort of helping to mitigate inflammation. I feel like inflammation and gut health are like the new, that's all
Yeah.
I want people to talk about.
Just like everyone's talking
Um,
about menopause, they're talking about those things too.
yes,
Yeah.
thank God, thank goodness, right? So dry skin and itchy skin. I make my husband scratch my back every night, and he the other day was like, I'm like, should I get a doormat and nail gun it to the wall of our bedroom and just like, scratch my own back at night, because it's so that I think is one. And then face dryness, you brought up the estrogen for that. I've also been prescribed an estrogen cream for my face,
Yes. That's
which
this thing great
I
too.
don't know if Winona carries that, but if you don't, it's something I think to look into, because I have friends ask, "What are you doing? What did you have?" Not that my skin looks particularly great or anything. I'm not trying to say that, but just my skin looks more supple. And I said, I'm on this. I've taken this cream, and it seems to sort of plump up the skin a little bit.
It really does. Now, we actually do have a face cream as well. So, our pharmacist actually, we made a combination cream that has both estriol and tretinoin, which, tretinoin, you might know like from things like Retin-A and some other, it's used for acne, but it's also used for its anti-aging benefits. It really helps with renewal of the skin. And so we have those products combined so that it's really helping with the skin texture, as also in addition to the estriol helping with the increasing the hydration and the suppleness and the elasticity of the skin of the face. So yeah, it's a great
Wow.
product. Ours is, I think, the only one right now that has both the tretinoin and the estriol combined in it.
Okay, we've got to talk offline about that, because I'm very excited about that new development. Okay, I saw some reel, and I thought this was hilarious. This woman said my joints snap like a glow stick, and when I go up and down the stairs, I can hear my hips,
Yes.
cracking. And I also suffered terribly last year from frozen shoulder and was having cortisol shots. It was really, really painful. Those are two other right symptoms, and
They can
what do we
be.
do? What do
Yeah.
we do for those?
And that can be from the loss of estrogen in the joint spaces specifically. So, not only when we age are we prone to things like arthritis, and we're more prone to arthritis in joints that we've overused throughout our lifetime. So, if you're someone who worked with their hands a lot, you're more likely to get arthritis in your hands. If you were someone on your feet or doing a lot of squatting and whatever job you did or whatever it was that you did with regularity, you might get more arthritis in your knees and your hips. I played softball for a lot of years. And so I was a catcher and I used to squat, as a catcher, and my hips are awful. But when you notice those joint pains getting dramatically worse in midlife, it's due because of the loss of estrogen from the joint spaces themselves. Like our synovial joints and our joint fluid and the joint spaces, like the cartilage, it doesn't function its best when our estrogen levels are low. So HRT helps that as well.
Okay.
So that's something that you can be treated with HRT in addition to all the other symptoms we talked about.
Okay. And then what about, would that also be like taking collagen supplements? Is that a joint? I know there's different, I forget who I asked about that it's protein and it can't really hurt, but maybe it's not, there isn't necessarily direct scientific proof that the collagen powder
I
does
think
a
that,
lot.
yeah, I mean, and now you'll see all these people kind of pushing more of these liquid collagen supplements. That's what I see. They're giving samples of in my Costco, and I'm seeing ads
Yes.
all the time for these people drinking this liquid collagen concoction. There's not great data out there in the medical literature yet to really say that something we consume that is being processed by our GI tract is going to get absorbed and cross, the tissues and get into our bloodstream to get to those tissues. But there's some people that swear by it, but I don't know. I haven't seen the data compelling enough for me to start taking it just because, I like to know that it's really going to be worth it for me to add something else that's another supplement. But protein in general, I think, is something that we should talk about because women do not get enough protein at
Yes,
all.
I know you've got like 1,000 things to do today, so I want to be quick on the time. Brain fog and loss of muscle mass we talked about, but brain fog also, is that HRT?
Brain fog can definitely be helped by HRT. Yeah. What I mentioned
Okay.
earlier is that, when we don't have estrogen in adequate levels, our neurotransmitters can't be actually produced or function as well. So you need estrogen in that equation for those to work better. So the brain fog improves when you go on HRT for sure. And also when
Okay.
you're helping your sleep and you're sleeping better with estrogen on board, that helps with your brain fog as well because the sleep deprivation makes brain fog worse.
Yes, so true. That is so true. Okay, you brought up protein. My last and final question for you is a little broad, but so much is coming at us. I know you're getting the same stuff. I feel like I screenshot reels about what kind of supplements I should be taking going through this period of life,
Mhm.
how much protein I should be eating, weighted vest, no vest, weight, fiber, magnesium. Fiber, magnesium, I feel like are big. Creatine is thrown at me. Can we talk about protein, fiber, supplements, and
Yeah,
anything else that you
absolutely.
think, or whatever I'd love to have like, this is what you need to be. You let me off the hook with the collagen powder just then. But
Yeah.
what do we really have to have as part of our war chest for keeping healthy during this time?
The real bare basics is that if you eat as much of healthy foods and you eat as many different colors of the rainbow as possible, you'll get the nutrients you need from your diet. But we're human, right? And in America, we are, or we're a group of people that are, looking for convenience and ease. And so sometimes we don't always eat the best. Sometimes we get things on the road. And so in that sense, you want to add back in the things that are really critical for you. So for us, as we're aging as women, it is so important for us to get enough calcium and vitamin D. That helps our bone health, our bone strength, in addition to the weight bearing exercise and movement and estrogen levels. But that's really important. Magnesium is something that I take regularly because I don't think I get enough of it in my diet. Like, and you could look up and see like what foods have enough magnesium and add those into your diet. That's probably a more efficient way for your body to extract those minerals. But for me, I use magnesium at bedtime to kind of help with sleep. It helps with calming, but it also helps with cognition and brain health as well. So, I mean, I personally take a magnesium supplement.
All right, Dr. Mike, can I ask you one question? How
Yeah.
many milligrams for magnesium, and then for calcium? Do you need to take a calcium supplement if you're not? I know broccoli's got calcium, and obviously dairy has calcium.
I mean, if you take a good women's multivitamin, it'll have both things in it.
Okay.
And I don't think there's a great, guideline as far as specific milligrams that you need, but there's several different forms of magnesium, and that's the other thing you have to think about. There's magnesium citrate, there's magnesium gluconate, there's magnesium L-threonate. Mag citrate is something we use to prep the bowels before doing a colonoscopy, or we use it for, constipation. So you have to be careful. If you take too much of that, you might give yourself diarrhea.
I have had a cautionary tale. I've had an issue with taking the wrong magnesium. But what is it? It's glycinate you want at night.
Glycinate is good for night, but also
Okay.
for the brain health, magnesium L-threonate is also good for brain health. It's another isomer of magnesium, but it's supposed to cross the blood-brain barrier better as far as for brain health. So that's something that this is recommended as well.
Okay, so should we take both of those, or is there one that maybe has?
I think that you could probably pick one or the other, and it's probably just
Okay,
fine. I would steer away from the magnesium citrate, basically, because of the
okay,
diarrhea issue.
okay,
Yeah.
okay. No citrate, glycinate, or L38.
L-threonate. It's
Okay.
yep, Threonate. Yep.
Oh, three on. Oh,
Yep.
okay. I'm
And
gonna
then
put all this
as
in.
far as protein, I'll tell you, like, you can Google and you can look up, and now with all the AI and search engine stuff information, you could say, like, at a height of this and, a body weight of this, what should my protein intake be to maintain my muscle? And it'll give you a protein goal. When I did this and I looked and found a chart, and there's very different sources you can look at, but for me, I'm 5'8", and I have to get 120 grams of protein a
I
day
know it's a
for
lot.
fat loss and muscle maintenance. And that's not to bulk up. That's just to maintain the muscle mass that I have. Because I think women don't realize we lose muscle at an alarming rate starting at midlife and after. Part of that's because of the loss of our estrogen, but part of that is with aging too. When you really think about how much protein that is, it's a lot. Like if you do MyFitnessPal or you do a Fitbit tracker or anything like that, where you put in everything that you're eating and it gives you your macros of what you're getting in as far as fiber, protein. I think if you tracked for one day to see how much you were getting in, see how much you're actually getting. When I was doing that, I was barely getting 50
Oh, I know it's
grams or
shocking.
60 grams of protein. And so now I've added in protein shakes in the morning. And instead of getting granola bars for my kids, I'm buying protein bars now to try to get everybody more protein, and everyone's healthier. It just seems like you have more energy, more get up and go when you have enough protein. And the other thing women have to realize is the way that we used to lose weight years ago by like fasting and maybe eating like a bird and trying lower calories, it's not so important. It's not a simple equation of calories in, calories out. Like you have to get quality nutrition. Think about whole foods. Think about your bigger macros, like making sure you get enough protein and you're getting enough fiber. Don't worry about the individual calories so much. Make sure that you're focusing on getting healthy, lean protein, eating a lot of raw vegetables and fruits each day, because that'll help with your fiber intake too. Because you want to keep your body functioning its best. So, I mean, like I said earlier, eating as many different colors of the rainbow as possible is really good too.
I, like you, had a number in my mind about where my protein should be, and I think it was like around 140, which I think is probably not right. I need to do the AI thing, but I that is really hard. It's
It is.
really, really hard to get there.
Yeah,
But certain things I notice, like the collagen powder, which might not help with maybe my nails and my hair and necessarily, it does have 15 grams of protein, and I put it in my coffee.
right.
Or, I'll have cottage cheese as the snack because you're going to get 12 grams in one of those little tiny cottage
Exactly.
cheeses. So
Yeah.
sort of I'm trying deliberately to kind of get there, but it is not easy. And
It's a
fiber,
struggle, right?
is it 30 grams of fiber a day? What is the fiber? There's also fiber powder my sister-in-law gave me that I will put in stuff too, because it's very hard to get the fiber, but getting natural fiber obviously is best. But if you can't,
What I keep at home is Benefiber because it's one of the ones that you can sprinkle into anything. It's not like our grandmother's old Metamucil that they used to take. You can sprinkle it on the top of food and it just kind of gets absorbed and you don't even notice it's there. Anytime my kids tell me that they feel constipated or they can't poop easily, I'm always sprinkling it into their food without
yeah,
even knowing it, and it helps. Yeah, so that's something that I think is good. And then, making sure you're getting a lot of, green leafy vegetables, looking for more whole grains rather than simple carbs, like going for brown rice rather than white rice, going for the whole grain breads, the things that are, maybe sprouted rather than really highly processed, wheat. And, a lot of people are doing gluten-free stuff now. And when you do that, you're getting a lot more quality grains when you're not doing the highly processed things.
interesting. All right, so protein, we're gonna everyone should do an AI assessment, see where they are, hit their goal. Vitamin supplements, a multi is good, but you also probably want to throw in some vitamin D. You want to be aware of your calcium and your magnesium, citrate, or you say the other one,
L-threonate.
L3 and 8. Then fiber,
Yeah.
30 grams a
I think
day?
30 grams a day is a good goal. If you get above
Okay.
that, that's great too. But I think as a minimum, I think that we should try to shoot for that.
And then we talked about the importance of weight training, weightlifting
Yeah, and just
for women
movement. I mean, just moving your
and
body.
movement.
Yeah, and that's why the weighted vests are so popular. You mentioned that earlier, but that's why people are getting those because it's a way to get resistance exercise with normal activity like walking. Like you could put a weighted vest on and do your housework and you will by far be stronger and your body will be, healthier doing that than just doing the housework itself. Little things like that, like little changes like that, but also just trying to, I mean, walking is a great exercise. I think that too many people underestimate the power of walking because every time you walk, you have impact, you have resistance of your body against the ground, and so it really is helpful.
And walking, I know sort of 10,000 steps was the popular
Yeah,
goal, but apparently that's not necessarily true for everybody. It could be 7,000 for some people, it could be 8, it
right.
could be 12, depending on your profile. And there are apps that do that too.
Yeah. And I think that now at this point, it's just like getting any walking in. I think as a society, we're too sedentary. We tend to drive to work and then we sit at a desk or, we're not as active as we used to be years ago. And just adding in movement and adding in walking is just any amount would be better than none.
Okay. Dr. Brown, thank you so much. I'm so, so grateful to you for coming on. I learned a ton.
Good.
I've got some things I want to follow up with you on about from tons of different creams and other supplements and things. So really grateful to you. Thank you so much.
Well, thank you so much for having me. And if you like the way that I talk or explain things, my team at Winona would like me to share that you can find me on Instagram. It's Dr. Kat OBGYN. And also for anybody that wants to learn more, if you want to read more about perimenopause and menopause, we have a huge section of our website that is free for anybody. When you go to the Winona webpage at winona.com, there's a section where if you pull down the menu, it just says learn. There are articles that have been curated by me and some of the other doctors. It's really good information. We have free symptom trackers that patients can download. You don't have to be one of our patients to do it. So there's a lot of free resources because we really, really believe that education is important.
Yeah.
And we hold free webinars twice a month, on our app that patients can dial into, ask questions. But I just want women to feel empowered to learn as much as they can about this and share the information with other women in their lives. Like, don't gatekeep the information. There's so much that I think that we can take better care of ourselves if we just learn more about our bodies and demand the care that we need. I think it's so important.
100%. And that's so great to know that you don't have to be a patient to get access to those resources. But if you aren't getting your questions answered with your local doctor or your gynecologist, knowing that Winona is there, as a resource, and you can be a patient anywhere in the country and have access to this wonderful doctors like Dr. Brown who can help you navigate this very, very tricky transition in life that every woman will go through. So, So grateful to Winona for being there.
Thank you. And thank you so much for having me.
Oh, thank you so much. That brings us to the end of this episode of Duologue. A huge thank you to Dr. Kat Brown for joining. If you're suffering from menopausal symptoms or you feel like your healthcare provider just isn't listening, or you have questions or you just want more information, go check out Winona's website at www.bywinona.com. They have incredible resources and healthcare professionals there that can help you. Also, a huge thank you to our sponsor, Karoon. Don't forget to check out their website. They have the most beautiful products. Trust me, you will not be disappointed. Their website, again, is www.karoon.com. And don't forget to enter the promo code Duologue at checkout for 20% off. That's just for our Duologue listeners. And last but not least, thank you all so much for listening and for all your support of the podcast. It means the world to me. If you enjoyed this episode, please rate or review us on Apple Podcasts or Spotify or wherever you get your podcasts. We release a new one every Wednesday. And don't also forget to check out our new website and subscribe to our Substack, where you'll get even more content and more exclusive information and giveaways. It's a Substack you won't want to miss. So until next Wednesday, this is Leslie, and thank you for joining us on Duologue.